In this lecture, we'll be discussing about primary open-angle glaucoma. Now, the definition of glaucoma. It is a group of disorders characterized by progressive optic neuropathy, which results in characteristic appearance of the optic disc and a specific pattern of irreversible optic field effects that are associated frequently but not invariably with raised intraocular pressure. Now, in the definition, there are three important things to note. That glaucoma, it is a progressive optic neuropathy which results in characteristic appearance of the optic disc. So this is the first thing you need to note: characteristic appearance of the optic disc, specific pattern of irreversible field effects, optic field effects, and which is usually associated with raised intraocular pressure. So these are the three important things to note in the definition: the characteristic appearance of the optic disc, specific pattern of irreversible optic field effects, and raised intraocular pressure. Now, out of these three things, if two are present, then it is known as glaucoma. Now, in this lecture, we'll be discussing about primary open-angle glaucoma. Now, it is the type of glaucoma where there is no obvious systemic or ocular cause in rise in intraocular pressure. If there is any specific systemic or ocular cause, then it is known as secondary open-angle glaucoma. Now, primary open-angle glaucoma, it is also known as chronic simple glaucoma of adult onset, and it is typically characterized by four things. The first is a slowly progressive raised intraocular pressure. The second is an open normal appearing anterior chamber angle. The third is characteristic optic disc cupping, and the fourth is special visual field defects. Okay, so the four important characteristics of primary open-angle glaucoma is a slow progressive rise in intraocular pressure, open normal appearing anterior chamber angle, characteristic optic disc cupping, and special visual field defects. Okay, now if you want to justify the definition of glaucoma, we have the three important entities here: raised intraocular pressure, characteristic optic disc cupping, and visual field effects. Okay, so hence this satisfies the definition of glaucoma. Now, coming to the etiopathogenesis of glaucoma. Now, in primary open-angle glaucoma, the increase in intraocular pressure, it occurs due to a decrease in the aqueous outflow facility. Okay, now the normal flow of aqueous humor is, if you look into this diagram, this is the iris, the ciliary body, the lens, and this is the cornea. Now here we have the trabecular meshwork. Okay, the normal flow of aqueous humor is that it is produced by the ciliary bodies and it flows through the posterior chamber into the anterior chamber, and from here it drains out through the trabecular meshwork. Now here we have the canal of Schlem, and through the canal of Schlem it drains into the episcleral veins. Okay, so this is the normal flow of aqueous humor. So again, it is produced in the ciliary body, it flows through the posterior chamber into the anterior chamber, and it drains out through the trabecular meshwork, canal of Schlem, and into the episcleral veins. Now, the changes in the outflow of aqueous humor, it is caused by age-related thickening and sclerosis of the trabecular meshwork, or narrowing of the intertrabecular spaces, apposition or collapse of the Schlem's canal, and deposition of amorphous material in the juxtacanalicular spaces. So again, the basic pathology is that there is a decrease in the aqueous outflow facility. Now, this can be due to thickening and sclerosis of the trabecular meshwork. This results in the narrowing of intertrabecular spaces, and another cause can be apposition or the collapse of the canal of Schlem, or the fourth reason is due to deposition of amorphous material in the juxtacanalicular spaces. So this is the pathology of primary open-angle glaucoma. So remember, there is a decrease in the aqueous outflow facility due to, number one, thickening and sclerosis of the trabecular meshwork, which results in the narrowing of intertrabecular spaces, or there can be apposition or collapse of the canal of Schlem. Now, the risk factors for primary open-angle glaucoma is age, race. It is more common in myopes, diabetics, hypertension, and cigarette smoking. So these are the risk factors. Now, moving on to the clinical features. Now, the symptoms: the disease, it is insidious in onset and usually asymptomatic. until it has caused significant loss of visual field. Okay, so the patient usually comes to the OP until there has occurred significant loss of visual field. Now there can be certain non-specific symptoms. These are headache and eye ache, difficulty in reading and close work, and this is due to constant pressure on the ciliary muscle, which results in accommodative failure. And the patient complains this as frequent change in presbyopic lens. So this symptom here should be noted. The third is delayed dark adaptation. The fourth is scotoma, which is a visual field defect, which we'll discuss later on in this video. And if the patient comes with at a very late stage, then there can be significant loss of vision and blindness. So these are the symptoms. So we have, usually it is asymptomatic. The associated non-specific symptoms include headache and eye ache, difficulty in reading, and frequent change in presbyopic lens. Now the signs. Now the signs of glaucoma can be divided into 4. The first is the anterior segment signs, where we look at the cornea, lens, anterior chamber, etc. The second is intraocular pressure changes. The third is glaucomatous optic nerve head changes, and the fourth is visual field defects. So again, note that the definition of glaucoma: intraocular pressure changes, optic nerve head changes, and visual field defects. So these are the signs. So we'll discuss each in detail, beginning with the anterior segment signs. Now the anterior segment, it is usually normal. Okay, pupillary reaction becomes sluggish in later stages, and the cornea may show slight haze. Now the anterior segment is usually normal. What do you mean by this? That is, there is an open. Why is it called open angle? It is because the iridocorneal junction, this iridocorneal angle where the trabecular meshwork is present, is open. Okay, and that is the first sign. That is the anterior segment signs. They are usually normal. The second is the intraocular pressure changes. Now in the initial stages, the IOP may not be raised permanently, but there is an exaggeration of the normal diurnal variation of intraocular pressure. Now for this, we do the diurnal variation test, and here the intraocular pressure is measured every 3 to 4 hours for 24 hours. Now a variation in intraocular pressure over 5 mmHg is suspicious of, and that over 8 mmHg is diagnostic of glaucoma. And in later stages, the IOP is permanently raised above 21 mmHg, and it ranges between 30 and 45 mmHg. Now note, the normal intraocular pressure ranges from 10 to 20 mmHg, and this is the second sign, that is intraocular pressure changes. So this can be divided into initial stage and early stage. In initial stage, it is not permanently raised, but there is an exaggeration of the normal diurnal variation, and for this we do the diurnal variation test. And here, if the intraocular pressure changes is over 5 mmHg, it is suspicious of glaucoma, and if it's over 8 mmHg, it is diagnostic of glaucoma. And in later stages, it is permanently raised above 21 mmHg. So these are the first two signs: anterior segment signs and intraocular pressure changes. And remember, anterior segment signs, they are usually normal, and it reveals an open angle in the anterior chamber. And the intraocular pressure changes in the early stages, if the change is above 5, it is suspicious of, and if it's above 8 mmHg, it is diagnostic of glaucoma, and in the later stages, it is permanently raised. Now moving on to the glaucomatous optic nerve head changes. Now the glaucomatous changes in optic disc, it can be divided into early glaucomatous changes, advanced glaucomatous changes, and glaucomatous optic atrophy. Okay, now before we discuss the glaucomatous changes, let us look how a normal optic nerve head appears on examination. So this here is the diagram, and here we can see the optic disc, the optic cup, the retinal vessels, the veins and the arteries, and we can see the macula and fovea. So this is the normal diagram of the optic nerve head. So again, let us just draw. So what do we see? We see an optic disc, an optic cup, the retinal vessels, the arteries and the veins, and here we have the macula and fovea. Now if you look into the optic disc, the area between the optic disc and the optic cup is known as neuroretinal rim. Now if you look back into the definition of primary open angle glaucoma, there is characteristic optic disc cupping. That is, the optic cup, because of progressive damage to the retina, there is optic cupping. Okay, so if this is the eye, this is how the, if this is your eye, the optic nerve enters like this. Now because of the increase in intraocular pressure here, the lens gets pushed back and this damages the retina, and because of progressive damage, what happens is there is optic cupping. So there is destruction of the neural tissue and there is optic cupping. Now if you come back, we've discussed the how a normal optic nerve head appears. Now let us discuss each of the early advanced glaucomatous changes and the glaucomatous optic atrophy. Now beginning with the early glaucomatous changes. Now there are 5 points to be noted. The first is that there is a vertically oval cup due to selective loss of neural rim tissue in the inferior and superior poles. So first point is vertically oval cup. Second is that there is asymmetry of the cups between the two eyes. The third is there is a large cup with cup disc ratio greater than 0.4. Now a normal cup disc ratio is 0.3 to 0.4. Fourth is the presence of splinter hemorrhages on or near the optic disc margins, and the fifth is the atrophy of the retinal nerve fiber layer, and these defects appear as wedge shaped dark areas arising from the optic nerve head. So let us draw this and learn. So first there is a vertically oval cup, okay, and there is second is large cup with the cup disc ratio greater than 0.4. The third is that there is asymmetry between the cups of the two eyes. So again, the first is vertically oval cup. Second is there is a large cup with cup disc ratio greater than 0.4, and the third, there is asymmetry between the cups between the two eyes. Okay. Now the fourth is the presence of splinter hemorrhages on or near the optic disc margins. So this is the splinter hemorrhages. And finally we have atrophy of the retinal nerve fiber layer, and this can be seen as wedge shaped dark areas arising from the optic nerve head. Now I haven't mentioned the retinal nerve fiber layer. Now this entire background is the retinal nerve fiber layer, okay, and in early glaucomatous changes, the retinal nerve fiber layer, it appears pale, or there is pallor of the retinal nerve fiber layer. So again, the early glaucomatous changes, we have the first is vertically oval cup, the second is a large cup, the third is asymmetry of the cups between the two eyes, the fourth is presence of splinter hemorrhages, and fifth is atrophy of the RNFL, and this can be seen as pallor areas and wedge shaped defects. Okay, so these are the early glaucomatous changes. Now coming to the advanced glaucomatous changes. Now the advanced glaucomatous changes, there is marked cupping, that because of progressive damage to the retina, there is marked cupping, and hence the cup size becomes around 0.7 to 0.9. Second is thinning of the neuroretinal rim. Third is the nasal shifting of the retinal vessels, and they have the appearance of being broken off at the margin, and this is known as bionetting sign. The fourth is the pulsations of the retinal arteriole may be seen if intraocular pressure is very high, and the fifth is the lamellar dot signs, that is presence of slit-like pores on the lamina cribrosa. Now the lamina cribrosa, it is a mesh-like structure of the optic nerve head that surrounds and supports the retinal ganglion cells as they form the optic nerve. So again, let us draw the advanced glaucomatous changes. The first is, so this is the optic disc. The first is marked cupping. Okay, the first is marked cupping. and because of marked cupping there is thinning of neuroretinal rim. Now the third is there is a nasal shifting of the retinal vessels. Now they appear as though they are being broken off at the margins. That is, they begin to branch after they begin. Usually they branch before the before the margins, but here they get broken off at the margins, and hence this sign is known as bionetting sign. So this is the third. The fourth is that there is pulsations of the retinal arterioles, and finally there is lamellar dot sign, that is a slit-like pose in the lamina cribrosa. So these are the advanced glaucomatous changes. So again, if this is the optic disc, we have a large optic cup. Because of the large optic cup, there is thinning of the neuroretinal rim. There is a nasal shifting of the retinal vessels, and they appear as being broken off at the margins, and this is known as bionetting sign. The fourth is pulsations of the retinal arteriole, and the fifth is the laminar dot sign, that is slit-like pose in the lamina cribrosa. Now finally we have the glaucomatous optic atrophy. Now here, as the damage progresses, all the neural tissue of the disc is destroyed, and the optic nerve head appears white and deeply excavated, as you can see in this diagram here. Okay, so here what happens basically is, if this is the eye and this is the optic nerve, because the damage progresses, there is excavation of the retinal tissue, and this appears as white and deeply excavated. So again, the glaucomatous optic atrophy, as the damage progresses, all the neural tissue of the disc is destroyed and the optic nerve head changes. Optic nerve head appears white and deeply excavated. So let us revise the optic nerve head changes. Now remember, a normal optic head, it consists of the optic disc, the optic cup, the retinal veins, the retinal arteries, and the fovea and macula. Between the optic disc and optic cup we have the neuroretinal rim. Now in early glaucomatous changes, there is a vertically oval cup with increased in cup size, it is greater than 0.4. Then there is asymmetry of the cups between the two eyes, presence of splinter hemorrhages, and atrophy of the retinal nerve fiber layer, which is seen as pallor areas of the RNF of the retinal nerve fiber layer, or it can be seen as wedge shaped dark areas which arise from the optic nerve head. In advanced glaucomatous changes, we have marked cupping. Because of marked cupping, there is thinning of the neuroretinal rim, there is nasal shifting of the retinal vessels, and as a result there is the retinal vessels, they appear as though they are being cut off at the margins, and this is known as bionetting sign. And fourth is that pulsations of the arterioles can be seen. And finally the lamellar dot sign, that is the slit-like pose in the lamina cribrosa. And finally we have the glaucomatous optic atrophy, and here the optic nerve head, it appears white and deeply excavated. So these are the glaucomatous optic nerve head changes. So to satisfy the definition of glaucoma, we've discussed the IOP changes and the glaucomatous nerve head changes. And in primary open angle glaucoma, there is characteristic optic cupping. Now moving on to the third, that is visual field defects. The visual field defects appear only after about 40% of the axons have been destroyed. Now the sequence of changes of visual field defects in glaucoma is usually asked short note or a short essay. Now you have to study it in the same order. The sequence of changes are: the first is isopter contraction, that is, there is mild generalized constriction of the central as well as peripheral fields. So the first is isopter contraction. The second is barring of the blind spot. Now this refers to the exclusion of blind spot from the central field, as you can see in this diagram. This here is the blind spot, and there is exclusion of the blind spot from the central field. The third is the small wing-shaped paracentral scotoma. Now it is the earliest clinically significant visual field defect. Now if you remember, one of the non-specific symptoms of glaucoma is the presence of scotoma. Now it may be seen above or below the germs area. Now the germs area, it is an arcuate area extending above and below the blind spot between the 10 10 degrees and 20 degrees of fixation points. So this here is the germ spot. Okay, so the third visual field defect is the small wing shaped paracentral scotoma. Now here you can see a superior paracentral scotoma. Okay, so we have isopter contraction, barring of blind spot, and now small wing shaped paracentral scotoma. The third is the Siedel's scotoma. Now what happens is the paracentral scotoma joins the blind spot to form a sickle shaped scotoma, and now this is known as Siedel's scotoma. So this is the fourth. So again the order: isopter contraction, barring of blind spot, small wing shaped paracentral scotoma, and now Siedel's scotoma. Now the fifth is the arcuate or the Jerum's scotoma. Now it is formed at the later stage by the extension of the Siedel's scotoma. So you can see this here is the Siedel's scotoma. Now it extends such that it becomes the arcuate or the Jerum's scotoma. Now this progresses into the double arcuate or the ring scotoma. Now it develops when the two arcuate scotomas join together. So we have one on the superior side and one on the inferior side, and these two join together form a ring scotoma or a double arcuate scotoma. Now you can note here that the joining of this it is not perfect. Now this gives rise to the next visual field defect, that is Rene's central nasal step. Now it is created when the two arcuate scotomas run in different areas and meet to form a sharp right angled defect. So this here is the Rene's nasal step. So again let us revise: isopter contraction, barring of blind spot, small wing shaped paracentral scotoma, then the Siedel's scotoma which joined with the blind spot to form the first is the isopter contraction, then barring of blind spot, then the superior paracentral scotoma. Now this superior paracentral scotoma joins the blind spot to form the Siedel's scotoma. Now the Siedel's scotoma, it extends to form the Jerum's scotoma or the arcuate scotoma. Then it extends downwards to form the double arcuate or the ring scotoma. Now they do not meet perfectly, and here a right angled Rene's nasal step is formed. Now the eighth defect is that this spreads towards the periphery and there are peripheral field defects. And ninth is advanced glaucomatous field defects. Now the visual field loss gradually spreads until a small island of central vision is left, and this is known as tubular vision. Okay, so this here is the tube of vision. Once the visual field defect has spread peripherally, only a tube of vision is seen, and this is known as tubular vision. So again the steps or the sequence of visual field defects is important. So first we have isopter contraction, that is constriction of the central as well as peripheral fields. Then we have the barring of blind spots, exclusion of the blind spot from the central field. Then we have a paracentral scotoma, a small wing shaped paracentral scotoma which joins with the blind spot to form the Siedel's or the sickle shaped scotoma. Now this extends to form the arcuate or the Jerum scotoma. Now this then forms the double arcuate or the ring scotoma. Now the ring scotoma, they do not meet perfectly, and hence Rene's nasal step is formed. Next the visual defect spreads periphery, hence we have peripheral field defects. And then advanced glaucomatous field defect is that finally once the disease has progressed, only a tube of vision is seen, and this is the tubular vision. So these are the sequence of visual field defects. Again for revision: isopter contraction, barring of blind spot, small wing shaped paracentral scotoma, the Siedel's scotoma, arcuate or the Jerum scotoma, the double arcuate or ring scotoma, Rene's nasal step, peripheral field defects, advanced glaucomatous field defects, that is tubular vision. Now a point to note is in the retina, the retinal fibers from the nasal side come to the optic disc as superior and inferior radiating fibers, whereas that from the temporal side come as the superior and inferior arcuate fibers. Then near the macula we have the papillomacular bundle. Now the point to note is that the superior and inferior arcuate nerve fibers, the superior and inferior arcuate nerve fibers are the most sensitive to glaucomatous changes. whereas the macular fibers are the most resistant to glaucomatous changes, and because of this, it is why the characteristic sequence of visual field changes are seen. So again, these two, the superior and lower arcuate nerve fibers are more sensitive, whereas the macular bundle is least sensitive. Okay, so these are the visual field effects. So this concludes the signs of glaucoma. We've discussed the anterior segment signs, that is, it's usually normal. Then the IOP changes, we mentioned the diurnal variation test, and in later stages it is permanently raised between above 21 mmHg, ranging between 30 and 45 mmHg. Then we discussed the glaucomatous optic nerve head changes. We discussed the early, the advanced, and the glaucomatous optic atrophy, and finally we discussed the visual field effects. Okay, so these are the signs of glaucoma. Now coming to the investigations to be done in a patient coming to the OP with glaucoma, is the first is tonometry, that is measurement of the intraocular pressure. This can be done by applanation tonometry or Schiot's tonometry. The second is central corneal thickness. Now a thinner cornea underestimates and a thicker cornea overestimates intraocular pressure on applanation tonometry, and hence it is important to know the central corneal thickness. Third is a diurnal variation test, which we've already mentioned. Remember, if it's greater than 5, if the variation is greater than 5, it is suspicious of, and if it's greater than 8, it is diagnostic of glaucoma. The fourth is gonioscopy, where we look at the anterior chamber angle, and in primary open angle glaucoma, a wide open angle of anterior chamber seen. Fifth is the documentation of the optic nerve head changes. Sixth is the documentation of the visual field effects using perimetry. Seventh is the nerve fiber layer analyzer to know the glaucomatous change to the retinal fibers. And eighth is the water drinking test. Now in water drinking test, glaucomatous eye, the principle is that the glaucomatous eye, it has a greater response to water drinking. Now after an 8-hour fast, the patient's baseline intraocular pressure is noted, and the patient is asked to drink 1 liter of water, and the intraocular pressure is noted every 15 minutes. Now the maximum intraocular pressure is noted in 15 to 30 minutes, and it returns to normal after 60 minutes in both the normal and the glaucomatous eye. However, if the rise in intraocular pressure is greater than 8 mmHg, it is diagnostic of primary open angle glaucoma. So this is the water drinking test. So again, the investigations, we have tonometry, central corneal thickness, diurnal variation test, gonioscopy to measure the iridocorneal angle. Then we have documentation of the optic nerve head changes and documentation of the visual field effects using perimetry. Then we have the nerve fiber layer analyzer, NFLA, to know the glaucomatous changes to the retinal nerve fibers. And finally we have the water drinking test. So these are the investigations to be done in glaucoma. Now the diagnosis. Now depending upon the level, depending about 3 things, we can come to the diagnosis. First is the level of intraocular pressure, second is glaucomatous cupping of the optic disc, and third is visual field changes. So based on these 3, we have 3 diagnoses. If all 3 are present, then it is known as primary open angle glaucoma. That is, there is increase in the level of IOP, glaucomatous cupping of the optic disc, and visual field changes. If only intraocular pressure is increased without any optic disc changes or visual field changes, it is known as ocular hypertension. Now, in the absence of increased intraocular pressure, if there is glaucomatous cupping of the optic disc and visual field defects, then it is known as normal tension or low tension glaucoma. So these are the 3 diagnoses. Moving on to the management of glaucoma. Now the aim of treatment, it is to lower the intraocular pressure to a level where further visual loss does not occur. Okay, now the grading of glaucoma can be done as mild, moderate, and severe. Now in mild, there is characteristic optic nerve head abnormalities, but their visual field is normal. Whereas in moderate, the visual field abnormalities in one hemifield but not within 5 degrees of fixation, and in severe glaucoma, visual field abnormalities in both hemifields within 5 degrees of fixation. Okay, so difference between moderate and severe is that in moderate, visual field abnormalities are seen in only one hemifield, but it is not seen within 5 degrees of fixation, whereas in severe it is seen in both hemifields and within 5 degrees of fixation. So this is the grading of severity of glaucoma. We have mild, moderate, and severe, and the aim of the treatment, it is to lower the intraocular pressure to a level where further damage does not occur. And if it's mild glaucoma, the intraocular pressure is brought around 18 mmHg. In moderate, it is brought to less than 16 mmHg, and in severe, it is brought to less than 14 mmHg. Okay. Now the therapeutic choices, it includes medical therapy, laser trabeculoplasty, and trabeculectomy or filtration surgery. Okay, so the therapeutic choices, we have medical therapy, laser trabeculoplasty, and trabeculectomy. Now let's begin with the medical therapy. Now the various drugs that are used to treat glaucoma is number one, beta blockers. Now the mechanism of action, they reduce aqueous humor secretion by its effect on the beta 2 receptors on the ciliary process. Okay, so beta blockers, they reduce aqueous humor production. The usually used beta blockers are timolol maleate 0.5% 1 to 2 times a day. Now it is the first drug of choice for medical therapy of primary open-angle glaucoma. The other beta blockers are betaxolol and cartiolol. Now betaxolol, it is used in patients with asthma, whereas cartiolol can be given to patients with hyperlipidemia and associated atherosclerotic cardiovascular disease. So remember, the first drug is beta blockers. They reduce aqueous humor production, they reduce aqueous humor secretion. Now the examples are timolol, betaxolol, and cartiolol. Now timolol maleate, it is the first drug of choice, betaxolol for patients with asthma, and cartiolol with patients with atherosclerotic cardiovascular disease. Now the second group of drugs is alpha adrenergic drugs. Now the mechanism of action is that it increases aqueous outflow by stimulating the alpha receptors in the aqueous outflow system. Now they are not the first drug of choice because of the increased allergic reactions. Now the examples of alpha adrenergic drugs are brimonidine and epinephrine hydrochloride. Now the third is prostaglandin analogs. Now they increase the UV scleral outflow. Examples are latanoprost 0.005% or travoprost and bimatoprost. The fourth drugs are the carbonic anhydrase inhibitors. Now they decrease the aqueous humor production. Now there are topical and oral carbonic anhydrase inhibitors. The topical carbonic anhydrase inhibitors includes dorzolamide and brinzolamide, and the oral carbonic anhydrase inhibitors include acetazolamide. Now remember, dorzolamide, it is given as 2% solution 2 to 3 times a day. Now the fifth group of drugs is myotics. Now the mechanism of action of these drugs is that it causes the contraction of the longitudinal muscles of the ciliary body and opens the spaces in the trabecular meshwork. Hence, it increases aqueous outflow. And the myotic used is pilocarpine, but it is not used widely since in young patients it causes problems due to spasm of accommodation and meiosis. Now the sixth drug is osmotic agents such as mannitol, and a newer group of drugs is in the development, and these are the neuroprotective agents. So in the medical therapy, the drugs are, you can remember the code glaucoma. So B for beta blockers, timolol, betaxolol, and cartiolol. L for latanoprost, travoprost, bimatoprost, that is prostaglandin analogs. O for osmotics like mannitol. C for carbonic anhydrase inhibitors. M for myotics, and A for alpha adrenergic drugs like brimonidine and epinephrine. So these are the drugs used in glaucoma. Now they can be given as monotherapy or combination therapy. Now monotherapy, the drugs preferred are either topical prostaglandins or topical beta blockers, and in combination therapy what we do is we give one drug that decreases aqueous humor production and another which increases aqueous outflow. So the combination of these two drugs are given. Now the usually given combination is timolol and latanoprost. So this is the medical therapy. The second is laser trabeculoplasty. Now it is indicated when there is non-compliance to medical therapy or when the intraocular pressure is controlled despite maximal medical therapy. Now the laser trabeculoplasty is where you use a laser to make holes in the trabecular meshwork. Now the usually used lasers are the argon laser and the diode laser. So this is the laser trabeculoplasty. The third is the surgical therapy. Now it is indicated when there is uncontrolled glaucoma despite medical therapy and laser trabeculoplasty, or when there is failure of medical therapy, or non-compliance to medical therapy, or with eyes with advanced diseases. Now the types of surgery are trabeculectomy and filtration surgery. So again, in the treatment we discussed that the aim is to reduce the intraocular pressure where further damage does not occur, and if it's mild, the target pressure is 18 mmHg. If it's moderate, it is 16 mmHg, and if it's severe, it is 14 mmHg. Now the first is medical therapy, where we discuss the various drugs. Glaucoma is the code, beta blockers, latanoprost, osmotics, carbonic anhydrase inhibitors, and remember the dorzolamide and brinzolamide are the topical agents, whereas acetazolamide is the oral agent. Then myotics like pilocarpine, and finally alpha adrenergic agonists like brimonidine and epinephrine. So these are the drugs used, and it can be given as monotherapy or combination therapy. Monotherapy, either beta blocker or prostaglandin, and in combination, one that decreases production and one that increases outflow. And the usually given combination is timolol and latanoprost. Then we discussed that the second is laser trabeculoplasty, and it is done when there is non-compliance or when IOP is still raised despite medical therapy, and here we use argon laser or diode laser. And then we discussed surgical therapy, where we use trabeculectomy and filtration surgery. So this concludes our discussion on glaucoma. So we discussed the definition. Now remember the three entities in definition: IOP changes, optic nerve head changes, and visual field defects. If two of all three are present, it is known as glaucoma. Then we discussed primary open angle glaucoma, that is without any systemic or ocular causes of increase in IOP. And we discussed the characteristic four things, that is there is an open angle, of course, then there is optic cupping, the third is visual field defects, and the fourth is increase in IOP. Then we discussed the signs, and we discussed the pathogenesis of glaucoma, that is decreased outflow due to causes in the trabecular meshwork, and this can be due to sclerosis or thickening of the trabecular meshwork, leading to decreased size of the intertrabecular spaces. Then we discussed the signs and symptoms. Now signs, it is usually asymptomatic unless significant visual loss has occurred. Then we discussed the signs. The important signs are the anterior segment sign, which are normal, then the glaucomatous nerve head IOP changes, then the third is the glaucomatous optic nerve head changes, where we discuss the early, the advanced, and the glaucomatous optic atrophy. We drew the normal optic nerve head and discussed the various changes. Then we discussed the visual field effects. So remember the visual field effect: isopta contraction, barring of blind spot. Then we discussed the paracentral scotoma, the cedral scotoma, the germs or the arcuate, the ring arcuate, the renase nasal step, the peripheral visual field effects, and finally tubular vision. Then we discussed the investigations to be done and the diagnosis, the three diagnoses, that is primary open angle glaucoma, ocular hypertension, and normal tension or low tension glaucoma. And finally we discussed the management, where we discussed medical therapy, laser trabeculoplasty, and trabeculectomy. And this concludes our discussion on glaucoma.